And Tom, I'd like to thank you and Fen for having me and to be able to discuss genetic testing today. And as you stated, very important, and its importance has only grown over the last several years with our knowledge of how it impacts patients with prostate cancer. In the past, really it was thought to be just relevant for breast cancer and a few other types, but has become very important in the realm of prostate cancer. So tonight I'd like to touch on three things really. I want to talk a little bit about metastatic prostate cancer and where the genetic testing comes in, as that was really where this knowledge began for the prostate cancer patient. Then go over genetic testing and who should be tested and how they should be tested appropriately in the future. So I'd like to get started first with talking about metastatic prostate cancer. And for those of you that are familiar with metastatic prostate cancer, that's in men where the cancer has spread outside of the prostate gland. Fortunately, it doesn't happen with most men, but it does. And until more recently, there have been limited things that we can do to help treat these people and help them along their journey with treatment of the disease. In the past, we really just thought of metastatic prostate cancer as a relatively simple process. It started out with the identification of patients with metastasis. And then they followed two divergent paths at first. They were either sensitive to what we call castrate or hormone treatment, or they're resistant to the castrate or they're resistant to hormone treatment. Eventually, though, every patient that starts off that's sensitive, as you can see here on the timeline, will develop resistance. And then eventually, over time, and this could be many years, the patients will progress. And then we went on to some types of treatments like chemotherapy, and there's a whole lot we could offer the patients. Much more recently, though, we're able to offer these patients a lot more. So this simple timeline has become a lot more complicated over the last several years, but in a good way, in that we have more options to treat patients with that have this problem. When a man is identified with metastasis, again, they'll have the two divergent pathways, but they start off treating regardless of whether they're sensitive to hormone therapy or not. They're treated with that, and we'll talk about that a little bit more in a minute. Again, the patient will develop resistance, but now rather than just going on to progress, there are other treatments available. And as we see here, the hormone therapy, what we call ADT, is the foundation or the basis of treatment, but then there are new treatments which can be used, and you can start with one and move to another, and then a progression occurs, you can move on to other forms of therapy. Even if they fail, there are other options which in the past weren't necessarily available, and we're lucky that we have them now. Really, the best thing to think about, though, is treatment for metastatic prostate cancer is like a pyramid, where the base or the foundation of that pyramid is always going to be hormonal therapy, regardless of anything that we add on top of this to the top, where we finally may run out of things to offer patients. And I'll keep that in mind as we talk. So when the ADT does fail, there are several options like I talked about, and we saw in that more complicated timeline. The one thing is, though, that we can definitely agree on is that there's no agreement on what we need to do first, and people debate that, and there's really not a good answer as far as the sequence of how we treat these. But the options we do have when you have failure of the hormonal therapies are a couple of different things, and they're very different types of treatments. The first one is what we call Provenge, and the complicated name for this is Sipuleucel-T. And this is an immunotherapy, so it's not a chemotherapy. It's not really a drug. It's using your own body to fight off the cancer, the defenses, kind of like you would fight off an infection. The second form of therapy that we have available to us are new hormonal therapies. And these go by the names of Zytiga and Xtandi. And these are things that are used frequently, all three of them potentially, in any kind of order depending on the patient's and the doctor's preferences. But now there are new therapies, and we saw that again on the timeline as you move through and some of these therapies stop working. There have been recently approved, just in the last few months, 2 new therapies. And these are for men that fail castrate or hormone therapy, and they become castrate resistant. The only problem with these therapies, unlike anything else in prostate cancer with the treatments, is that the eligibility or who we can treat these patients with depends on diagnostic tests. It only works in certain men, and it only works in men that have genetic abnormalities. So that brings us into who we test. Is it just these metastatic men, or is it a bunch of different men, and why? And I'd like to talk about this genetic testing as an overview and who, how, and when we test men. So the first question that always comes to mind is, why do we even do genetic testing? And the simple answer to that is, we want to identify mutations or abnormalities in the genes that have implications on cancer. Now, could be the treatment of the cancer, or it could also be on how we follow or how we watch or how closely we watch men, where the treatments may not be appropriate at that point, but maybe in the future. Genetic testing is relatively simple. It can be done on blood or saliva, or finally tissues. And that tissue is usually ones that are taken from the initial biopsy that men have, or if they've had surgery, it can be taken from the prostate itself, from the cancer tissue that was there, but it requires specifically cancer tissue. If none of that is available, and the cancer unfortunately has spread someplace, you are able to get some tissue potentially from the areas where the cancer may have spread. The genetic testing provides us with information that's valuable that could definitely impact your treatment in the future. The other thing that genetic testing can do is it can identify family members that may also have the similar or same genetic abnormality that could really specify having the future of prostate cancer, but other cancers like breast cancer, ovarian cancer, and even pancreatic cancer. And we'll talk a little bit about that in the future. How common is this? It's relatively common. It's found that about 1 in 6 prostate cancers are caused by inherited, so it's genetic mutations that men are born with. So things that they've carried through their whole life. And we'll talk a little bit more detail about that. So the genetic mutations, every cancer, every single one, starts with a genetic mutation. That mutation makes the cell not respond or grow normally, and it starts to divide uncontrollably, because that's really what cancer is. It's uncontrolled cell growth. So the mutations cause the cancer cells, to lose their ability to grow and function normally. This can cause a cancer to behave more aggressively in some cases, and it also can affect how a patient may respond to certain specific treatments. There are 2 ways that mutations occur. There's what we call germline, which is heredity. So these are inherited mutations, but also cancers can occur sporadically, and they can occur because cells become cancerous by developing a mutation that the person is not necessarily born with. And there's specific differences between these 2 types of mutations. On the germline side, these tests can be relatively simple. This is done again on blood or saliva samples. In some cases, it can be done on tissue, but it's much easier to get blood or saliva samples. These mutations are always inherited, which means that they are found in every single cell of the body, not just in the cancer, but everywhere. They're found, and they can be transmitted to future generations as well. These will help guide treatment options, and they'll also provide a risk assessment for your family to see if they're at risk of developing cancers in the future as well. On the other side, there's the somatic mutations. These are tested on the tumor. So you actually have to have the cancer tissue available, because that's where the abnormality is. These are not found in every cell of the body, but they're found in every cancer. There's always a mutation. Sometimes we can identify it and sometimes we can't. So these also, just like the germline mutations, can help us guide treatment options, but they don't necessarily give you any information at all regarding your family or the development possibly of other types of cancer. Excuse me. So let's first talk about the somatic test. We know that in metastatic cancer of the prostate, about 28% of men will show, or we can detect, a mutation in those men. So it's relatively high. It's almost 1 in 3 that we can find it. And again, this can impact their medical management in the future. The problem with it is you don't always get enough cancer tissue to identify these mutations, and the failure rates to be able to identify them can be as high as 44%. It's generally lower than that, but it can be that high, which can be frustrating at times, that the mutation may be there, you just cannot find it. So the other issues with somatic testing is that mutations can change, is that the original tumor may not have the same mutation as what has developed later on in the disease process. So those mutations can change. The other problem could be if you can't get the cancer tissue from the original biopsy or even the surgical specimen, sometimes you have to do another biopsy, which can be difficult to do or difficult to obtain tissue on. So usually we try not to do a repeat biopsy, especially if it's in the bone or some area that may be difficult to get to or even painful to get. Germline testing, on the other hand, is very simple to get. It's done on blood or saliva samples. It will give you hereditary status, so that's what is inherited and what you've got, from your parents, potentially. It also tells us that there's a risk of additional possible cancers. So if you have a hereditary mutation that is passed along from your parents, there is a possibility that you could be at risk of other cancers. And in men, that could be things like pancreatic cancer. It could be certain types of cancers in the kidney, or even colon cancer. These tissue samples can be done at home, because with saliva, or if at the doctor's office, again, on a blood sample. So what are the implications of these genetic hereditary germline mutations? Well, we know that from previous studies that men that are found to have a germline mutation are 6 times more likely to die from the prostate cancer within 5 years of diagnosis compared to men that don't have these germline mutations. So it's a very, very more aggressive type of cancer that develops from a germline mutation. We also know that they're 4 times more likely to develop metastasis or spread of their cancers within 5 years of diagnosis as well. So even though they may not die in that time period, they're much more likely to develop a spread of their cancer, again, than men that don't have these types of mutations. So it's important to identify these things, because we need to know this to develop the treatment plan for men that have these problems. The implications of the germline mutation. Here we see a family tree. The green shaded are people that are affected. So you can see that if there is a germline mutation present, 50% chance that this will get passed on to the children. And then also, if you go the other way, if a man is affected, let's say here, there's a 50% chance that his children might have a germline mutation. But there's also, if you go the other way, if they're a younger man that this is developed in, there's even a 50% chance that one of his parents has that germline mutation, which could be an implication for developing a cancer even in your parents. We should never forget, it's not always passed down, but we know it goes in the opposite direction as well. And this information can be very helpful for family members in identifying cancers earlier and to prevent the problems that these types of cancers can cause. So the question now comes, who do we test? I mean, do we test everybody that has cancer? And we'd like to say yes, we probably should, but right now we're kind of in that point where, since this is a relatively new finding, especially in prostate cancer, that we're kind of tied to what we can do according to specific guidelines and other issues. So we know that right now, and we talked a little bit about this earlier, that we always can test men that have metastatic prostate cancer. It's important to them because of the immediate treatment implications, drugs that we can use to treat these men. We know that we can test men that have higher risk cancers. And we usually talk in terms of Gleason score to identify these men. And a Gleason score of 8 or higher is usually a high risk type patient. We also can do lower risk men, or men that we say that have intermediate risk, that have certain family history involved. They can be Ashkenazi Jews. They can have another family member that has other types of cancer as well, such as ovarian, pancreatic, or breast. Or they can have 2 family members that have, at any age, and including much older, developed either breast or prostate cancer. So what else can we do with these men? Well, just recently, it was said that men that can go on to have certain types of treatment options can be tested for specific types of genes. And these are 2 that were most commonly found, which are the breast cancer gene 1 and 2. And although it's called the breast cancer gene, it is the most these are the most common genes that we find that are associated with prostate cancer as well. So we recommend that all men that have these, that we are able to get these tests on, have these germline tests of the BRCA1 and BRCA2, regardless of any of their past family history. So if they're positive, then they can be treated accordingly. Well, if they're not metastatic, they can be followed more closely so they hopefully won't develop any problems. And if they are metastatic, then we can have certain treatments that are available to these men. The important thing is when you do testing is that the quality of the test is appropriate. And what that means is you want to be able to identify appropriately the highest number of men that have these mutations. If you don't have good testing, such as some of the tests that are available direct to consumer, which don't always test for all the genes, because there's thousands of variations in some of these genes. And it's nice to know that companies that do quality testing can identify some of these variations, whereas a lot of the direct-to-consumer type tests that you see advertised on TV are not equipped to be able to identify the larger numbers. Companies like the one I work for, Myriad, developed these tests and has 30 years of genetic testing experience and have tested over 3 million patients and has a bank or a library of all these different kinds of mutations greater than any other lab so that we can identify the highest number of mutations. And it's important if you get tested to be able to identify the highest number of mutations so you don't miss anything, so that you can be adequately treated or followed. So now that we know the importance of genetic testing, the question is, how do we achieve these tests? And the important thing is with these is it's a doctor initiated. So your doctor is involved in the testing process. And you can identify, just like we talked about, with a checklist, which for the metastatic prostate cancer, a high risk or a lower or intermediate risk with certain family history characteristics. If they qualify regarding these issues, then you can be covered for testing, and then you should be tested. The other thing you can do is, if you want to look at this on your own, you can go to such digital websites that look at screening for you and say, am I a candidate? Am I appropriate for testing? And the one that we like to recommend is very simple to remember. It's theprostatecancerquiz.com. And this will be a simple 30-second or so test asking questions that are specific to the cancer that you may have. And it will tell you at the end, right then, if you are an appropriate candidate for hereditary testing. And if you are, you can get tested at your doctor's office, and the process is relatively simple. It's a blood or saliva sample. It's collected there. It's shipped off to the company, and then it's tested. The results go back to your doctor, who then talks to you about the results of the test, either in the office or these days, a lot of it is done remotely, and can go over what the results were and what needs to be done. More recently, though, and this has been kind of spurred on because of the COVID pandemic, is you can get your genetic testing done at home, where the doctor orders a kit. It's sent directly to your house. You submit a saliva sample. It doesn't have to be a blood sample. And then that's sent directly back to the lab. And then again, the doctor gets the results and can then call you and go over the same results that you would get as if you had taken the test in the doctor's office. So I'm going to end here as we have more further presentations, and I'll be happy at the end of the presentations to ask questions. And again, Tom and Fen, I want to thank you again for allowing me this opportunity to share the importance of germline and genetic testing. So with that, I'll stop my presentation and move on to Dr. Crawford.
Thank you, Dr.